And Dr. Coleman's going to join me for this lecture, as she is a pediatrician in our department who's been trained in sports medicine as well. So we're going to go through some cases here. Please feel free, again, open forum. Please ask questions if you have any thoughts. So I'll let her start off.
Okay. Well, good afternoon, everybody. So our first case is an 11-year-old male soccer player. We've got lots of those in this area. He collides with another player who doesn't do that while playing soccer or any other sport, and he twists his knee. We hear this a lot. Immediately his knee swells, and he has pain, obviously, and someone has to help him off the field. He can't walk on his own. So he comes to you 2 days after the injury, and he really can't walk still on his own. He needs to kind of have his parents help him, or he's using someone's crutches, or he's just limping along. And his knee gives out on him when he goes upstairs. His history is otherwise healthy, no medical problems, no surgeries in the past. When you examine him, you notice he's got lots of swelling, large effusion, he's tender everywhere. And it's difficult to examine him just because of his pain, but you feel like when you're doing the drawer test or any other stability test that it's just moving a little bit more than it should. He's neurovascularly intact, so he's got good pulses and good cuff refill. What's next? Okay, so what would you do? So let's see. So first, would you send him to the ER? Anyone? Raise your hand. No? Would you get x-rays? Raise your hand. Yeah, would you get an MRI? To send him for MRI? Okay. Would you consult a colleague or the internet or something like that? Oh, you send him to... Woohoo!
He's more likely to have a disruption of ligament.
Okay.
I would send him to the ortho, let the ortho order the MRI.
Okay. Very good. Okay, very good. And then my last question was, would you send to ortho? Fabulous. So, yeah, whether you did it on your own or whether you just called and got him in with us today or sent him to the ER, somebody would get x-rays. So you can see here, do we have? Oh, here we go. Okay, so you can see we've got a couple x-rays here. One that's should be kind of an AP view, but it's a little bit of an oblique view of the knee. Actually, were you supposed to be explaining this? Sorry. And then we've got a lateral. So you always want to do two that are 90 degrees apart. So you can see he does have an effusion in his knee. You can see his open growth plates as well. We don't see a fracture, which is always good, too.
So we got sent to orthopedics at that point, and an MRI was ordered. And so what you can appreciate here on the MRI is an effusion again, not quite as large. But the structure you see here is the PCL, and the structure you don't see here that you'd like to see is the ACL. This is on your sagittal view, and if you look on the coronal view here in the notch, you should see the ACL coming up this way, heading towards the lateral aspect of the femur, and you don't see it here. And these cuts were not just selectively taken not to show you this is where you should actually see it on there. And so the ACL is torn in this patient's case, and this is actually another picture of a MRI, and you can see the actual ruptured ACL right here. So the key here in this scenario and the take-home message on the clinical exam portion is, number one, reports of instability. Number two, a large effusion. The ACL has a vessel in it, and when it's completely ruptured, that vessel will bleed, arterial bleeding into the knee until the pressure goes up in the knee. So they usually get a very large effusion. And their complaints of instability, anything that challenges the anterior translation of the knee, which is usually stairs or steps, they feel like the knee is going to give out on them. Those should all be warning signs in your head that even without a clinical exam that you might have a very unstable knee. So this happens about 1 in 3,000 in the general population. Adults and kids, up to 100,000 ACLs are reconstructed per year. 47% of pre-adolescents who present with a traumatic knee effusion have an ACL tear, okay? And 65% of adolescents who present with a traumatic knee effusion have an ACL tear. So when they come in with that large effusion, that should be a big red flag that something's up here. And a lot of times these aren't complete tears, and they get treated differently. So it's very important that we're able to differentiate between that. So when they talk to you about the presentation, they also often they will talk about the pain, the effusion, but a pop. Often there's an audible noise when they get a complete tear. And we talked about a couple of the general things you'll see: the effusion, tenderness, the anterior drawer test, what we call the Lockman's test, where you put the knee at 30 degrees and you control the distal femur and bring the tibia forward, is a little more sensitive in testing the ACL, but is really completely useless when you have a large effusion unless there's absolutely gross instability. The pivot shift test tests the secondary aspect. The ACL provides two primary roles. One, it prevents anterior translation of the tibia, and two, rotational stability. And the pivot shift test is looking at rotational stability. And then we want to sort of look at, when we do our evaluation, the next thing we'll do too is also look at skeletal maturity, because that's going to come into play in how we're going to address this. In general, for all these patients, they're going to get plain films because we want to rule out associated injuries as well. So there can be fractures and physeal injuries in particular in the skeletally immature that can be associated with, or can actually give you the pre-adolescent version of an ACL tear, which you see in this x-ray on the right, which is a tibial spine tear. The insertion of the ACL has literally been ripped out of the top of the tibia, and so in essence you have an incompetent ACL, but the ACL itself is actually intact. And so this is something we can often pick up on x-ray. So what do we do for these? Well, in the prepubescents who are low demand and there's no other interarticular injury, a lot of people recommend initially doing conservative therapy, activity modification. You can't play any sports. You can't do any kind of pivoting or any type of cleated activities that would put additional stress on the knee. And we often recommend an ACL brace, and then we monitor them to see if that instability resolves over time. And this is fine if it's a child less than about the age of 8. Oftentimes, though, this is challenging, particularly with the sports-inclined child. Those that have a partial tear, less than 50%, and a negative pivot shift test, those can also be treated conservatively and often will heal on their own and do not need a major operative intervention. However, if you have a partial tear that it does have a positive pivot shift or is greater than 50% of the ACL, that is going to have gross instability, and that does become more concerning for us. And oftentimes that will, if a positive pivot shift in an older child does, even if they're still skeletally immature, does sway us towards a reconstruction. And so for us, skeletal maturity and reconstruction decisions are within 2 years of skeletal maturity. So girls less than 12, boys less than 14. And in those cases, when we reconstruct them, I actually and my partners reconstruct them without going through the growth plates, or what we call physeal sparing procedures. And in essence, we create tunnels to reconstruct them with grafts that we harvest from the patient themselves, typically their hamstring tendons, and we put them through tunnels in the epiphysis of the femur and the tibia, and therefore decrease significantly the risks of secondary growth issues, either leg length discrepancies or angular deformities that can occur. In those that are skeletally mature or within 2 years of skeletal maturity, the literature has shown that crossing the physis is not as risky as once was believed, as long as the size of the tunnel is relatively small. And the argument recently has been 7 millimeters is the diameter that we go for. And then once you're at absolute skeletal maturity or very close to absolute skeletal maturity within months, we just go for the normal trans epiphyseal approach that we use in adults. And most commonly, we try to use the tissue from the patient themselves. We don't do what most adult orthopedists do, which is use allograft or donor tissue. We typically use the patient's own hamstrings or patella tendons for their reconstruction. The bad news is that a lot of these kids are very active and they're out of sports. So we have them back to most of their regular activities of daily living by 3 months, but they're not going to be back in sports for 5 to 6 months at the earliest. And I tell them all 6 months, and if they get in a little earlier, then they're happy and they think I did something great, and I really didn't. All right, case number 2.
Okay, so case number 2, we have a 9-year-old gymnast, and we've got a lot of gymnasts out in the area, who comes to you saying that her right knee has stabbing pain around the kneecap, and that happens all the time. Everybody has kneecap pain. And it happened about a year ago after she fell while doing gymnastics in a competition and twisted her knee. Once again, twisting injury. So she tells you it hurts all the time. It's worse when she starts walking on it. It's worse when she bends, and it's worse when she's sitting. So obviously the knee's bent again. She has pain with sleeping. No sensation changes, and she notes that if she's stretching or moving it, it feels like it locks, or it'll kind of catch. So on exam, you watch her walk, and she's limping. She can't heel or toe walk. She has full range of motion of the other knee, and hips. And on this knee, though, you can't get her straight. 10 to 15 degrees of extension is missing in her right knee. So when you're examining her, you feel a clunk, and we all know clunks are not good. And she has pain with passive knee flexion extension. She has normal strength, sensation, neurovascular status on that side. And then when you check the McMurray test, which is kind of internally and externally rotating the tibia and the femur while you're extending and flexing the leg, it's painful, and you hear it pop too. So what would you do? So would you send her to the ER? No. Would you get x-rays? Would you send her for the MRI? Would you Google it or consult somebody in the office? I'm a big fan of Google. Or would you send her to ortho right away? I feel good. I like it.
Right. So what do you think? So what do you think she has? A meniscal tear. Good. So you send her to orthopedics, and she gets x-rays. So we get x-rays again to rule out any other fractures. There are other issues that can occur. An osteochondritis dissecans, they could have a fracture of the cartilage that could be loose and cause a mechanical block to motion, and can also cause pain as well and have similar symptoms. Certainly we're going to get the MRI, and here on the MRI, what you can appreciate right here and right here is a meniscal tear. And so this is, again, you see an acute traumatic hemarthrosis, but it's usually not a very severe one. It's much more mild, maybe moderate at most, but nothing in comparison to what you see with an ACL rupture. And oftentimes kids can actually have a congenital setup for this. They can have a discoid meniscus where the center part of the meniscus never actually went away. It stayed solid throughout development instead of going through its usual apoptosis as it forms the normal meniscal structure. And so that can lead to a higher risk factor for having injury and pain and problems with it. But even in non-discoid meniscal tears, we see a 45% pre-adolescent rate and 45% adolescent rate if they have a mild traumatic hemarthrosis. And in presentation, differs from your ACL in that they will talk about giving way, but it doesn't feel grossly unstable. They usually have joint line tenderness over the compartment involved. There's often a clicking or a locking sensation. They feel like something's causing the knee to get stuck. And then it'll just sort of sometimes even spontaneously just present without a traumatic history. That's more common that we see with the discoids. And then again, as I said before, a mild effusion and a McMurray's test, as Dr. Coleman listed before. So we do get the plain films. There are those using ultrasounds now to evaluate these, but the gold standard for us still is MRI. It really does have a much better view. Unfortunately, though, in children less than 12, there is a decrease in its sensitivity and specificity. We do have a couple of musculoskeletal radiology specialists at Children's now, and we've gotten much more adept at interpreting these. Plus, the magnets have gotten better in the imaging, too. But there are developmental things that can imitate a tear, and so oftentimes, if we're not absolutely certain, we think there's a tear clinically, they look like they could have a tear, then the definitive way to tell is to put a camera in there and look at it. So in terms of the discoid meniscus, the treatment is to recreate the normal meniscus. So we do what's called saucerization. We take the middle portion out, and then we try to repair whenever possible the torn tissue, and if it's not repairable, we have to resect it. The thing that we talk about in regular meniscal tears, anything greater than a centimeter needs to be addressed. If it's less than a centimeter, it will probably heal okay on its own. The concern we have is long-term development of instability, pain, and arthritis. And what has been shown in adults is that if you lose a third or more of the meniscus, that does significantly increase your risk of getting arthritis. And so we take great pains in children to repair as many meniscus as possible and to prevent, to minimize resection whenever possible, particularly large resections of meniscal tissue. The problem with the meniscus is that it doesn't have a very hearty blood supply. Really, only the peripheral and middle portions of the meniscus get their nutrients from blood. The rest comes from the fluid in the joint. And so those that are in the more central portion of the meniscus just aren't repairable lesions. They won't heal. Okay, case 3.
I just want to say one other thing about the meniscal tear. If someone is lucky enough to have a meniscal repair and not have to have it pulled out, and they come to you and they're not on their crutches and they're walking on it, yell at them because they definitely need to be resting. It needs to heal, and if they're walking on it, it's not gonna heal up, and they might have to go back and have it pulled out. So if you see a young kid come back, say, I had my surgery, I feel great, and they're still walking on it, get those crutches back out.
12 weeks. So I protect them for a minimum of 12 weeks on a repair.
Okay, so our last case is a 15-year-old female field hockey player. She's coming in with 4 weeks of left knee pain, so this is a little different than our others who had one had acute, one had long-standing. This is kind of subacute knee pain. She has mild swelling. No known trauma, but lots of sports. People fall all the time. They knock knees all the time, and who knows what happened. And not everyone remembers if they actually had a big injury. And her symptoms are really severe when she's participating in her field hockey. She gets occasional clicking and catching, but obviously it hasn't been bothering her too much. She has a history of asthma, no hospital stays, and no surgeries. So on exam, you feel a trace effusion, not very large. No sign of traumatic injury, but once again, she doesn't give you a history, and it's been 4 weeks. She has a negative Lockman test, so it seems her ACL is stable. Negative anterior and posterior drawer test, so her ACL and PCL also seem stable with those tests. McMurray's is negative, so we're not particularly concerned about meniscal tear. But you do feel a click when you extend her knee, when you flex and fully extend her knee. What would you do? Would you get x-rays?
So for somebody, one person who said get x-rays, what would you get? What x-rays would you get?
Very
What?
good. Of the knee.
A knee, yes.
Yeah,
Yes,
very
the
good.
knee. Which
What views
knee
would you
x-rays
get?
would you get? A tunnel view.
Ooh, very good.
Yes, sir. Excellent. Yep.
Why tunnel?
Why a tunnel view?
Okay.
Yes,
Very good.
sir. Exactly.
Very good.
And that's really important because a lot of times I think we we don't always emphasize what's the best technique to identify some of these lesions. Now on your differential here, as well as osteochondritis, what else might be on your differential here? Anyone else? So this also could be patella instability and patellofemoral pain. So we often get patients presenting with trace effusions who have had recurrent subluxations of their patellas, or young females who are having a lot of patellofemoral pain. And sometimes we'll even get this presentation with the, quote, jumper's knee, or your patella tendonitis issues, which gets really exacerbated over time at the origin or insertion of the tendon, and you can end up with some swelling as well. But getting these x-rays, the most important x-ray you can get here is this x-ray that's on your far left, which is the notch view or the tunnel view. And that x-ray there, you can see it's very subtle and may not show up really well, I guess, on the big screen, but you can see on the lateral aspect of the medial femoral condyle, there's a abnormality there, and that is the most common location for an osteochondritis dissecans. It's on the lateral aspect of the medial femoral condyle, right at the tunnel, and that's where you see it. And on the lateral x-ray, you can often see it too. Here it shows up much better on the MRI, where it lights up nice and bright here, and you can see this is the area of concern here, and then on the sagittal reconstruction, you can see it here as well. So by definition, this is a disorder of subchondral bone. It's often due to a series of traumatic, usually we hypothesize it occurs over time. It's not common that it's just a one inciting event, although we can see chondral fractures. So we do see things that look similar to an osteochondritis, but really is a fracture just through the epiphysis. But more often this seems to be more of a chronic process. For whatever reason, there's this chronic repetitive injury leads to a vascular insult to the subchondral bone, and the cartilage either peels off or collapses. And so when they present, they will often have an antalgic gait. They'll often have knee pain, which is exacerbated by activity. But often when they get off of it, they'll tell you, oh, my knee feels much better. When I'm not running, when I'm not playing soccer, when I'm not doing gymnastics, my knee doesn't hurt. But when I go out and do these activities, it starts hurting. And then in worst case scenarios, once that subchondral foundation breaks free, they can get a loose body inside the knee, and they can get the clicking and the popping and the mechanical blocking we talked about. They often present with just a milder trace of fusion, if that. If they do have a loose body, they'll have joint line tenderness, and they can have crepitus or catching or locking. So again, the plain films can show it to you, but the plain films are better to differentiate what else might be on there. And this over here is an example of a young man who slid into third base and had this acute injury. And this is an acute achondral fracture. This is not an OCD lesion. He literally sheared off the lateral femoral condyle. And so that we obviously want to differentiate those kinds of injuries. CT defines the bone very well and is very good, but MRI has really been our workhorse in really defining these. And there's been a lot of literature written on how to change your treatment algorithm based on what you find on MRI, but unfortunately we don't have a definitive way yet. But what we do look for is the sign of fluid signals between the lesion and the joint. If we see communication of fluid between the joint and the lesion, that usually needs a more aggressive treatment, needs to be surgically repaired. If we don't see that, if we just see changes within the bone itself, we'll start them off with a conservative management of a minimum of 3 months, modified activities, modified weight bearing, and plus or minus PT depending on where they are in the course of their presentation. If they fail that treatment at 3 months, either with us or with you prior to coming to us, then we have to move forward with our surgical options. And again, with the smaller lesions, the activity modifications and mobilization, they tend to do very well. But in the larger lesions, and particularly those that show some sort of instability, they don't typically do as well. And so we can either do a direct repair where we go in, drill, and put a screw in to hold the fragment back in place so it'll heal. Or if the fragment is very small and not salvageable or in many small little pieces, we'll actually just debride out the fragment and then create a bed for healing by either drilling or using a pick to create bleeding so that you have blood flow in that area to create a fibrocartilage so that it will heal. Outcomes, well, 34% of untreated patients with juvenile OCD lesions have moderate to severe arthritis in the 4th decade of life, so I don't think it's something we can take real lightly. They have a very high healing rate when compared to our meniscal tears, so they typically do much better. They also, both meniscal tears and OCD lesions, have a much higher healing rate if they're done concurrently with an ACL, and quite honestly, we think that's just because we traumatize the area more, and so there's a bigger healing reaction, but we don't completely understand why that is. So red flags to consider in general for all of these different points. If you have a patient who comes in who's got night pain or persistent antalgic gait or recurrent swelling, if they have decreased range of motion or inability to bear weight, or any of the positive specialized tests we talked about, a Lachman's or McMurray, initially you can immobilize them, modify their activities, make them toe touch. It's not an emergency, but then contact your orthopedist so they can get in as soon as possibly reviewed. So thank you, and we'll take some questions now if you have any questions about sports.